Please join us for the Q&A. So we have questions. We can have questions from the floor. Please raise your hand. We also are broadcasting, so people who might have a question online, also please feel free to put it in the chat. And while you let all this information come to you and make a question out of it, I would like to have a first question to both the speakers. With the knowledge that you have showed us today, and it's a combination of things that we already knew and new things that you have showed us today, how could we prove in a prospective way that this would actually have a combined benefit? So would it be adaptive protocol studies, or what, with your large experience, would be an idea to actually prove in, let's say, a scientific way that this would actually have a better outcome?
Shall I start? Well, I think that's the $1 million question, of course, but I think it's not very helpful to do, again, large studies to compare 1.0 grams of proteins with 1.3 or a one-size-fits-all RCT. So if we want to do new studies in the field of critical care nutrition, I think we have to at least have some aspects of individualization. And it could either be models like Pierre alluded to with AI, predictive models of certain metabolic consequences of our nutritional interventions, or what I showed, maybe using techniques like indirect calorimetry and BIA or so, and maybe also to use monitoring. Because when you give your patient potassium in the ICU, when you have a low potassium level, you will probably not calculate the total body needs based on sex, body weight, height, and you say, my patient needs 41 millimoles of potassium. You just start giving something, and you measure the response. When it's okay, the potassium, you stop. When it's high, you stop. When it's still low, you increase the dose. So we're used to monitor the effect of our interventions. And with nutrition therapy, I understand that it will be very difficult to do. But we have to understand that the same potassium dose for our patient on day 2 may not be the best dose on day 7. And that's the same for all the things we do in ICU. But we have to learn also that this could be similar for critical care nutrition.
Well, first of all, regarding AI, prospective studies are difficult to achieve. And you could listen to a lot of talks in this Congress regarding AI. The program is full of topics regarding AI. And most of the studies are retrospective and then validation. But prospective studies telling to your patient, you can choose or my decision or the computer decision, what do you prefer, is a little bit challenging. So we will have to validate at the end of the day the process. And I think that we are on the way, but we have to more look at the data and the data that, Arthur, you are accumulating with energy expenditure and body composition is very important for analysis of artificial intelligence, because you are increasing the phenotype possibilities. And then you don't need a prospective randomized study, because you will be analyzing the results of what you are doing in comparison to what are your measurements, and you will see if you are giving more or less in comparison to the measurement, how the outcome is coming out. So in this way, you are able to create a better understanding of what's going on. And it's very complex because it's dynamic. And you showed also that when you are giving the certain dose in the beginning, it's different at the middle and it's different at the end. And when you look to the studies, they give also and so. And they don't understand the differences in the physiology and the evolution of the patient. It's a nonsense to give the same dose from the beginning to the end of an ICU stay, because the patients are changing. The muscle mass has disappeared. and the weight is different, and you are working only per kilo. So you have a lot of complicated issues to solve. So to answer to your question, I think that accumulating a lot of data, sharing the data, sharing the expertise, trying to put beside the prospective randomized studies that have failed, not only in our field, by the way, in most of the fields in ICU.
Of course. Thank you very much for indeed agreeing with us that also individualized research is necessary, because as you stated, we will not get the answers in this large variation. I also have a question, and also I was personally practically intrigued when I saw your publication on the failure or the feeding intolerance, let's say, of patients with a certain profile. You would have the old male patient with a high fat mass and a sepsis. You could actually be almost sure that this therapy will not work. Enteral nutrition will always be the first choice, and you will ramp it up. But as you showed in your conclusion, now we are running behind on the facts that we in fact already know. So from a clinical perspective, could we somehow implement this knowledge or even have a decision support where you say, okay, we could already know that in this patient it's not going to work, so let's have a combined strategy, which is also in line with recommendations. You are able to do that. But do you think that we can have a clinical implementation from what we have learned here today?
I think certainly yes, but you have to take into account that the units are different from one place to the other, and the populations are different. And you have units with a length of stay of 3 days, and others with a length of stay of 10 days. This is not the same population. So we will not be able to recommend the same approach to all these populations together. So when you want to use or you apply the artificial intelligence, you have to run the algorithm in each department and reinforce the results and adapt the results to the specific population. It's personalized, but also for the department, not only for the patient.
Of course. Thank you very much. We talk a lot about quantity, quantity of protein, quantity of energy. We have the protein lovers, the energy lovers here on the table. But the question about the quality was also addressed. A practical question once again. With the data that you have showed today, would you say that like the whey protein could be an option for when you have a patient with intolerance? Or would you just say maybe it should be like the standard? So what is your opinion with the data that you showed?
It seems that when you use whey protein, you have a better outcome in terms of intolerance. If you switch from one to the other, I'm not sure that you will get the same results. So you have a message here, but definitively you have to think if you want to start with that or to keep it as a second choice. It's an issue.
Professor Van Zanten?
Maybe I can add to that. I think, yes, we know, for instance, that casein coagulation can occur in the stomach and lead to slower gastric emptying. So yes, the composition of tube feeding is essential for gastrointestinal tolerance. But we also have not to forget that we are in the era of making the ICU and ICU nutrition greener. So maybe one solution could also be to use plant-based proteins in the product. So to combine maybe animal-based or milk-based proteins, but maybe also to have exclusive vegan products. And I'm happy to announce that several companies now are working on this product. I think this company already has one, but it's important. But we have to prove, like Pierre said, it's not only the enteral feeding tolerance that's important, it's also maybe what is the metabolic consequence of the protein composition for muscle protein synthesis or muscle mass loss in the future. So I think there is a lot of work to be done, but it's on our list now, the tolerance to enteral feeding. And we worked on definitions even recently during this week, so we will have clear definitions on enteral feeding tolerance in the future, also for research. So I think this will bring the field further.
Thank you very much. Do we have a question from the audience or someone would like to comment on a statement? Please, sir. Just 1 second for the broadcast. We would like to use the mic.
Okay. You have an ICU patient with sepsis. You start your feeding slowly, and then after 10 days you have a new inflammation attack. How do you reduce your food?
Yeah, maybe I can start. It's an excellent question. So we know we have to build up slowly in the initial phase of inflammation in the ICU, but of course there can be reoccurrence of inflammatory processes during the course of ICU stay. And what we see in many patients now monitoring UCR, that we see an increase in urine creatinine ratios, possibly telling us that the dose at that time, because then we're at the full dose after some time, may be too much. We have to be careful. There is no proof that reducing the intake at that time leads to a better outcome. It's highly likely because UCR is associated with worse outcome, but we don't know that yet. But we are now in a process of having a historical cohort of 1.5 years using dosing on total body weight. Now we're in the cohort dosing based on fat-free mass, and we will incorporate UCR data also to see what is the effect on outcome. So I think in 1 year or so we'll know a little bit more, but it's a challenging concept because when you have a huge inflammatory re-challenge in an ICU, probably endogenous energy expenditure will also increase again. So maybe we have to reduce the nutrition. But I'm not aware of any studies that have studied this, that it's essential to do. But it seems from a metabolic perspective, seems to be highly likely that we have to do it. Do you do it, Pierre?
Thank you to bring us back to clinical practice. Yeah. Definitely is a challenge because the patient with this second hit is changing his metabolic rate, is increasing again his catabolism, and he already decreased his muscle mass, and you are reluctant to decrease his protein load because you are afraid that you will be in a negative nitrogen balance again. But the anabolic resistance is back again. These are not the patients that have been included in studies. These are patients, this period of time, it's or the patient is recovering or is staying as a chronically critically ill patient, but you don't say, oh, the patient has a recurrent sepsis with septic shock again, of a VAP and so on. And this population is not well studied. So we don't know exactly. For energy expenditure, it is. But for management, what to do with these patients to go back to the start or to continue the same way or in between, you don't know.
Okay, thank you very much. May I please maybe ask you to walk up to us after the session because we are going a little bit over time, but please feel welcome to join us after the session. So I would really like to thank you to be here today to think about the concepts. I would like to thank both of the speakers that have talked about endotyping and critical care nutrition by Professor Van Zanten, harnessing AI for tail and patient care. And I exactly also want to, of course, thank very much Nestlé today for having us here, for organizing this, and for making knowledge transfer possible. And it will also end in a better care and a better nutritional care. So thank you very much. Thank you, everyone.